Hello and welcome to part 2 of our case files studies of the hypertensive encephalopathy case. We will continue immediately without further ado to continue our case about the hypertensive emergencies. We reached the pathophysiology of hypertensive emergencies, and now we'll continue. Please refer to video 1 if you have no idea what I'm talking about. So, cerebral blood flow is a good example of vascular compensation by vasodilation or vasoconstriction in response to changes in arterial pressure. In normotensive adults, cerebral blood flow remains relatively constant over a range of mean arterial pressures between 60 and 120 mm mercury because cerebral vasoconstriction limits excessive cerebral perfusion. Because cerebral vasoconstriction limits excessive cerebral perfusion. As the mean arterial pressure increases beyond the normal range of cerebral autoregulation, there is cerebrovascular endothelial dysfunction and increased permeability of the blood-brain barrier, leading to vasogenic edema and the formation of microhemorrhages. Patients then manifest symptoms of hypertensive encephalopathy, such as lethargy, confusion, headaches, or vision changes. Typical imaging findings on MRI include posterior leukoencephalopathy, usually in the parieto-occipital region, which may or may not be seen on CT scanning. Without therapy, the condition can lead to seizures, coma, and possibly death. The definition of hypertensive emergency does not require numerical threshold of arterial pressure, but is based on end organ effects. Autoregulation failure can occur in previously normotensive individuals at blood pressures as low as 160 over 100 millimeters mercury. However, individuals with long-standing hypertension develop adaptive mechanisms frequently, such as cerebral arterial autoregulation, and may not show clinical manifestations until the blood pressure rises to above 220 over 110 millimeter mercury. Thus, emergent treatment of hypertensive encephalopathy, and indeed all hypertensive emergencies, should focus on the symptoms rather than their numbers. In fact, it may be dangerous to normalize the blood pressure of patients with chronic hypertension. As consequence of the right shift in the autoregulation curve, these quote normal unquote blood pressures may lead to decreased perfusion to the brain, resulting in infarction or similar renal or coronary hypoperfusion and ischemic injury. Usually, a reasonable goal is reduction of mean arterial pressures by no more than 25% or to a diastolic blood pressure of 100 to 110 millimeter mercury over a period of minutes or hours. Treatment of hypertensive emergencies usually necessitates parenteral medications without delay. Direct blood pressure monitoring with an arterial catheter often is necessary. One of the most common used medications for treating hypertensive emergencies is sodium nitroprusside. It has the advantage of nearly instantaneous onset of action, and its dose can be easily titrated for a smooth reduction in blood pressure. However, its metabolite may accumulate, resulting in cyanide or thiocyanide toxicity when it is given for more than 2 to 3 days. Certain clinical situations may favor the use of other medications. Intravenous loop diuretics and vasodilators such as nitroglycerin decrease the preload, central venous pressure, in acute pulmonary edema. So they reduce the preload in acute pulmonary edema. Myocardial ischemia or infarction is treated with intravenous nitroglycerin to improve coronary perfusion and beta blockers to reduce blood pressure, heart rate, and myocardial oxygen demand. Patients with aortic dissection benefit from medications that reduce the shear forces affecting the aorta, which will help limit propagation of the dissection. A useful technique in treating these individuals is the use of intravenous nitroprusside to lower the arterial blood pressure and beta blocker to blunt reflex tachycardia. Alternatively, intravenous labetalol, a combined alpha and beta blocker, alone can be used. Patients presenting with acute cerebral infarction generally should not have acute blood pressure lowering because of the possibility of worsening of cerebral ischemia. The vast majority of hypertension has no discernible cause, so-called essential hypertension. Some patients have secondary causes, such as renal artery stenosis, hyperaldosteronism, hyperaldosteronism, aortic stenosis, or pheochromocytoma. A history of paroxysmal hypertension with headaches, palpitations, and hyperadrenergic state, like flushing, dilated pupils, diaphoresis. These suggest the diagnosis of pheochromocytoma. Pheochromocytoma are catecholamine-producing tumors that arise from chromaffin cells of the adrenal medulla. Other symptoms may include episodic anxiety, tremor, and orthostatic hypotension caused by volume contraction from pressure-induced natriuresis. Although uncommon, accounting for only 0.01% to 0.1% of hypertensive individuals, these tumors have important therapeutic considerations. The diagnosis is established by measuring increased concentration. Diagnosis of pheochromocytoma, sorry about the distraction. The diagnosis is established by measuring increased concentrations of catecholamines or their metabolites in either urine or plasma. Usually a 24-hour urine collection is assayed for metanephrines, vanillylmandelic acid, VMA, and unconjugated or free catecholamines. So 24-hour urine collection is assayed for metanephrines, vanillylmandelic acid, VMA, and unconjugated or free catecholamines. Whoa. After the biochemical test document the excess catecholamines, the next step is to locate the tumor for surgical removal. Approximately 90% of pheochromocytomas are in the adrenal gland, usually identified by computed tomography or MRI. The treatment of choice for these tumors is surgical resection, but it is critical to reverse the acute and chronic effects of the excess catecholamines prior to excision. Using alpha blockers, and you can use beta blockers, but you shouldn't be using beta blockers alone. So sometimes a beta blocker agent is started, but only after an alpha blockade is established. Okay, so in summary, a hypertensive emergency is defined as an episode of elevated blood pressure associated with acute end organ damage or dysfunction and requires immediate lowering of the blood pressure. Asymptomatic patients with elevated blood pressure usually can be started back on oral regimen and reassessed as outpatients in 24 to 48 hours. The cerebral autoregulation curve of individuals with chronic hypertension is shifted to the right. Nevertheless, Marked elevations in mean arterial pressure can exceed the ability of cerebral vessels to constrict, causing hyperperfusion, cerebral edema, and hypertensive encephalopathy. Pheochromocytomas may cause paroxysmal blood pressure elevations in association with episodic headaches, palpitations, and diaphoresis. Preoperative blood pressure control in pheochromocytoma can be achieved with the use of alpha blockers such as phenoxybenzamine. Beta blockers used alone can paradoxically increase blood pressure because of unopposed alpha adrenergic effect. Thank you very much, and this is all for our hypertensive encephalopathy pheochromocytoma case. Before I finish, I have this notice from the book itself to read, which is important for both me and the book and you. Medicine is an ever-changing science. As new research and clinical experience broaden our knowledge, changes in treatment and drug therapy are required. The authors and the publisher of this work have checked with sources believed to be reliable in their effort to provide information that is complete and generally in accord with the standard accepted at the time of publication. However, in view of the possibility of human error or changes in medical sciences, neither the editors nor the publishers nor any other party who has been involved in the preparation or publication of this work warrants that the information contained herein is in every respect accurate or complete, and they disclaim all responsibility for any errors or omissions or for the results obtained from use of the information contained in this work. Readers and listeners are encouraged to confirm the information contained herein with other sources. For example, and in particular, readers are advised to check the product information sheet included in the package of each drug they plan to administer to be certain that the information contained in this work is accurate and that changes have not been made in the recommended dose or in the contraindications for administration. This recommendation is of particular importance in connection with new or infrequently used drugs. Thank you very much for listening. Thank you for listening to my case file. And please don't forget to share, like, subscribe, or do all these YouTube things. Thank you so much. And now I'll continue to drink my coffee from my dirty cup.